Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture series in CNS examination. Now today we'll be starting with motor system examination. Very frequently will be asked in your oral, and good number of things can be asked as a short note also from this particular chapter. And in your everyday practice you will come across a person with neurological defects, particularly involving motor system. So it will be very helpful to you in your everyday practice also. So we'll be discussing under muscle examination. Motor system will include muscle examination, tone, power, involuntary movements, posture and gait, coordination, and reflexes. This involuntary movement, posture, gait, coordination, and reflexes will be discussing in a separate chapter. Today we'll be discussing mainly on muscle examination, muscle tone, muscle power. At the end, little idea regarding involuntary movement, posture, little idea, but mainly we'll be discussing separately. So motor examination does not mean the examination of this motor. This is also motor, but examining this is not a motor system examination. Now there are few terminology which will be very frequently utilized. We call paresis, means partial weakness. Normal power is 5 by 5. If it is less than 5 but more than 1, we call as paresis. While plegia means there is a total weakness, power is almost close to 0. And depending upon the number of limb involved, we use the word hemiplegia, paraplegia, quadriplegia, etc. And if there is a partial weakness, then hemiparesis, paraparesis, monoparesis, those words are utilized. So there will be, the term will be paresis or plegia, and depending upon the number of limb involved, if you got the 2 lower limb involved, we call paraplegia. If one side of the body, that is upper limb and lower limb on the same side is involved, we call as a hemiplegia. And if you got 4 limbs involved, then we call quadriplegia. And if on one side you get a lower motor neuron cranial nerve palsy and opposite side hemiplegia, then it is called crossed hemiplegia. These are few of the words. When the tone in the muscle is completely 0, we call flaccidity, or we use the word hypotonia. Flaccid or hypotonia. And if the tone is increased, we call that as a hypertonia. And in that we use some words like rigidity and spasticity. Spasticity is very commonly utilized whenever there is a resistance only in one group of muscle. That is frequently seen in case of an upper motor neuron palsy. Classical example in case of hemiplegia. While rigidity is in all direction, that is in flexion, extension, etc. And that is divided into two classical groups. We call lead pipe type of rigidity and cogwheel type of rigidity. While in case of spasticity, usually we come across a one group, what we called as clasp knife type of rigidity. So this will be the 3 common groups of rigidity which is being described. But the word spasticity is frequently utilized for upper motor neuron, while rigidity is a common word which is utilized for extrapyramidal system damage, and that will produce cogwheel rigidity and lead pipe type of rigidity, and that is very common in case of Parkinsonism. Gait is the type in which you are walking or style of walking, and depending upon the type you are walking, different gaits are being described. like hemiplegic gait, paraplegic gait, cerebellar ataxic gait, etc. Ataxia means failure of muscle to coordinate and irregular voluntary muscle action. And particularly while walking, if a person gets ataxia, he will have a tendency to fall on any side, either on the right side, left side. His balance will be not proper, and that we call as ataxia. Akinesia means total absence of movement. Hypokinesia means diminished motor movements. Bradykinesia is another word for hypokinesia, that is we call slow movements. And hyperkinesia means increased movements, that will be very commonly seen in an involuntary movements. We'll be showing you something in that particular. So plegia is partial weakness, paresis. Plegia is complete weakness, paresis is a partial weakness. We already mentioned hemiparesis, hemiplegia, quadruparesis, quadriplegia, paraparesis, paraplegia. So that are the words which are being utilized. We already mentioned flaccidity, decreased tone, atrophy, wasting of the muscle, hypotonia, loss of tone, and atonia means total tone absent. And because the tone is absent, the movement will be diminished or nearly absent. And this is a photograph showing you. You can see the tongue, and there was a very nice fasciculation seen in this tongue. This will be seen in a lower motor neuron type of a palsy, and that is classical in case of a motor neuron disease. So in a motor system, we examine different things like nutrition of the muscle, tone, power, coordination, posture, and gait. It will also include in a motor system, some people also includes reflexes. When you are examining, we look for partial or total weakness, whether there is any painful movements, particularly because of disorders of muscles, any reduction in the size of the muscle like atrophy, or increase in the size of the muscle like hypertrophy, any abnormal involuntary movements, and what type of difficulty he comes across, whether while working or while doing some activity or while standing or while walking, etc. All this has to be examined when you are going for motor system examination. So mainly while examining the motor system, we look for the muscle mass, and that we examine by inspection, palpation as well as percussion. And muscle tone is mainly by doing palpation of the muscle during active movement and passive movement. While power is during active or passive movement, you can feel the resistance by doing palpation. Involuntary movement is mainly by observation. Posture and gait is also by observation. Coordination will be done by many different types of tests. We'll be not be discussing in detail at present. We'll be discussing in detail in cerebellar disorders and cerebellum examination, and reflexes will be doing separately. So we'll be going through one by one. So while doing a motor examination, first is inspection, palpation, percussion. Then we go for examination of power, then position, involuntary movements, and any other things which you can differentiate that which group of muscles are involved, whether it is central or peripheral, and then you put the differential diagnosis. Now in inspection, first the part to be examined, say we are examining the upper limb. So complete upper limb should be fully exposed. It should not be covered by any particular clothes. So complete exposure of the part to be examined should be there, whether it is upper limb, lower limb, face, etc. Now when you expose that particular part, you compare right side with left side. You look at the symmetry. The side where there is an atrophy, it is usually very frequently in a lower motor neuron palsy. In a normal person, both sides should be equally bulky. So the side where there is a atrophy, usually that is a disease side. So whether it is localized in one part of the limb, or it is complete half of the body, or it is the whole body, we'll be mentioning few of the condition. Say, for example, if it is unilateral and say only in the palmar region and particularly the thumb part, then it will be very commonly because of the carpal tunnel syndrome, which is compressing the medial nerve. Say if the entire half of the body has undergone atrophy, say right upper limb as well as right lower limb, then it will be very common because of disuse atrophy in case of hemiplegia. But say there is an atrophy of all muscle, or we call muscle wasting of entire body, it will be very frequently in tuberculosis, malnutrition, malignancy, HIV, etc. So it will help you a lot. In case of a lower motor neuron palsy, along with atrophy, you will see little amount of fasciculation. I've already uploaded one video, small clip on fasciculation. Then you will have to look at which group of muscles are involved, whether it is a proximal muscle, distal muscle, whether it is a girdle muscle. So all those are very important. And during examination, without any movement, you look at the position of the limb. That also gives you an idea regarding the muscular weakness. Normally, when the lower limbs are there, they are usually internally rotated. When they are externally rotated and there is hardly any movement of the lower limb or upper limb, when you are asking a question and when you are examining the person, it indicates paresis or plagia. There will be some typical deformity which can be seen. And during a static stage also you can see some involuntary movements, particularly tremors. We call static tremors. And when you ask the person to walk, then we call examination or inspection of a gait part of it. So in inspection, you can have good number of things. You can look at the muscle bulk, you can look at the wasting, and you can look for fasciculation. Fasciculation is a small muscle, small part of the muscle which is going contraction, very rapid contractions in a localized part, that we call as fasciculation. And fasciculation are very frequently seen in two groups. One, in a fatigue muscle. Say person who has done an exercise for a long period and then we stands, you can see a small contraction in the muscle, that is called fasciculation because of fatigue muscle. But in a person who has got a wasted muscle because of lower motor neuron palsy, and in that wasted muscle, if you see fasciculation, those are called manifest fasciculations. And you can stimulate that fasciculation by tapping that muscle, and that will be latent fasciculations. Now, for tone, you will have to palpate the muscle when the muscles are in a relaxed position. If muscle feels flabby, that is hypotonia. And if muscle is giving a good resistance, that is normal tone. But if there is an increased resistance during palpation and it feels little hard, that is hypertonia. And while palpating also, you look for the tenderness. So if the muscle is tender, it is very frequently in a damaged muscle or a disorders of muscle, we call as inflammation of muscle, myositis, which can be inflammatory, very frequently in case of a viral fever, or can be even autoimmune. And that can lead to extensive involvement of the muscle. And when it involves multiple muscles, we call polymyositis. And also, when you ask the person to move the part of the body and you are testing for the muscle action, and during resistance, you are testing for the power. And you also look for the deformity. You try to identify the deformity, because deformity will be present because of fibrosis, or what we call as the muscle which undergoes atrophy will heal by fibrosis, and that will give rise to deformities. And good number of time deformity may be there because of joint involvement also, like in case of rheumatoid arthritis, psoriatic arthritis, osteoarthritis, you can have deformities. And also during the movement of the joint you can feel crepitus. So all those things should be examined. And you can induce fasciculation by tapping, or we call percussion, specifically in the tongue. When you ask the person to open the tongue and you just tap on the top part of the tongue by a blunt object, and if you get contraction of the muscle and the relaxation of the muscle takes a very long time, that will be classical in case of a myotonica congenita. While if you see a fasciculation even without the tapping, that will be very, very typical in a lower motor neuron palsy because of motor neuron disease. And also you can see a fasciculation in a wasted muscle in a lower motor neuron 12th cranial nerve palsy, that is hypoglossal. You will have a wasting plus fasciculation on the side of the damage in lower motor neuron. And then we check for the motor strength, that is power. So we'll be going through that. We'll be talking, or we'll be showing you some of the things in involuntary movement separately in separate lecture, but we'll be giving little idea. So while inspection, you look for atrophy, or we call bulk of the muscle, and you always compare with the opposite side. Simultaneously, you look for the small twitching in the muscle we call as fasciculation. Is there any hypertrophy? If there is a proximal muscle hypertrophy, or there is a hypertrophy but the power is reduced, that will be very frequently seen in a pseudo hypertrophy, or we call as dystrophy. And whenever the muscle is involved, whether it is proximal or generalized or distal muscles which are being involved, is there any deformity? Is there any abnormal posture? Is there any involuntary movements? These are all seen on inspection. And again, in involuntary movement, we'll be looking for tremors, which are resting, or we call static tremors, or when they are seen with outstretched arm, that are called intentional tremors. Whether there are any axial movements, we call chorea athetosis, abnormal posture, or if there is any seizures, which we call as motor seizures, like grand mal epilepsy. So these are all the things, these are for abnormal movements, which you can easily observe and confirm. Muscle bulk is always comparing with the opposite side. In lower motor neuron, there will be rapid wasting, so you will see the atrophy of the muscle early, and in the involved muscle. So whichever muscle is involved, that will undergo atrophy very fast, so that muscle bulk will be reduced. We call wasting or atrophy. And it will be good number of time localized muscle wasting. While in an upper motor neuron, it will be a big group of muscle involved. Say entire upper limb, entire lower limb, entire half of the body. And over a period of time, there will be disuse atrophy. In the person who are doing regular exercise, like athletes or sports, their group of muscle will undergo hypertrophy. These muscles are powerful muscles. So that is because of the good use of the muscle, and that has undergone hypertrophy. But if there is an hypertrophy of a group of muscle but the power is reduced, that will be very frequently seen in a person with a pseudo hypertrophy. We call dystrophic group of muscles, that is classical in Duchenne and Baker's. So this will be some of the congenital disorders which can produce pseudo hypertrophy. Also in case of a person with joint disorders like rheumatoid arthritis, cachexia, like tuberculosis, HIV, malignancy, malabsorption syndromes, malnutrition, severe hypoproteinemia, say in Kwashiorkor, marasmus, you will have a generalized wasting of the muscles. We already mentioned fasciculations will be irregular twitching seen in the muscle when they are resting, and very classically seen in a lower motor neuron involvement of the muscle. So muscle will be wasted, or we call atrophic, and in that atrophic muscle you will see that fasciculation. You can also see in a person with a fatigue muscle after a heavy exercise, say like marathon race, etc. You can see that. Without any particular stimulus, the muscle undergoes jerky movements that will be seen very frequently in a myoclonic epilepsy or myoclonic jerks, a rare involuntary disorder. And we already mentioned which muscles are involved: generalized involvement or proximal muscle or distal muscle involvement, any deformity if it is present, any abnormal posture, any involuntary movements. And we have already mentioned in involuntary movement, you look at the tremors, there will be good number of tremors, like tremors will be seen in hyperthyroidism, we call thyrotoxicosis. Also they will be seen in alcoholics. In Parkinsonism, there will be static tremors. Intentional tremors will be more in case of a cerebellar disorders. Few examples. So wasting of the muscle, you look, the muscle mass is reduced. Classically you can see here, there is a wasting of muscle. Here also you can see wasting, and there was fasciculation which was seen. Rapid and gross wasting will be seen in a lower motor neuron, while very mild wasting and gradual wasting over a period of long time because of disuse in upper motor neuron. Also you can get the disuse hypertrophy because of immobilization of the limbs because of the joint involvement or fractures, etc., or because of plaster. Then also you can get disuse atrophy in that affected part. The mass is increased, we will call hypertrophy, and pseudohypertrophy we already shared Duchenne and Baker's, that is called pseudomuscular dystrophy. You can see this is an hypertrophic muscle, but the power is reduced. And true hypertrophy you will see in an athletes. This is generalized wasting that will be very frequently seen in disorders which are producing generalized disorders like tuberculosis, HIV, malignancy, etc. And whenever you are looking at the muscle, you have to look in a relaxed position and you have to compare with the opposite side, and same group of muscles should be compared. And while doing palpation, you are palpating for the tone, so you are looking for the resistance when it is a passive movement and during active movement. So when the muscle is absolutely soft and flabby, it is very clearly classical. In case of lower motor neuron, we usually use the word hypotonia or flaccid. And if there is a good resistance or there is an increased resistance, it is we call as a hypertonia. In a normal person, there will be normal amount of resistance, and that increased resistance will be very frequently seen in an upper motor neuron. Then you can measure the muscle mass by taking a fixed bony point, and then at that bony point, fixed distance from that bony point, you measure the circumference of the arm or a leg part and compare with the opposite side. So if it is reduced, it is usually because of wasting. Both sides should be by and large equal. So this is how we measure. From a acromion process to the middle part of the arm, you measure the circumference and compare with the opposite side. So in the arm, 5 inches from the level of elbow. In forearm, 4 inches from the below the elbow joint. and at the knee 9 inches above and 6 inches below. You can depend upon the person to person, and you measure the circumference and compare right with the left, and that will give you the idea regarding any wasting if it is present. Here you can compare the two. Here you can see that there is definitely flattening of muscle. This is wasting, and this will be very commonly seen in case of a carpal tunnel syndrome. So unilateral wasting, very frequently lower motor neuron and in a small area, while unilateral involving upper limb, lower limb, very frequently seen in an hemiplegia because of disuse atrophy. Generalized wasting, we have mentioned tuberculosis, malignancy, malabsorption, HIV, Kwashiorkor marasmus, thyrotoxicosis, etc. Also, localized wasting can be seen after prolonged immobilization, usually if there is a fracture and the plaster was used, or a person who has got a severe deformity, and because of immobility of the joint you can get wasting. So look for that wasting, and in a wasted muscle you can see fasciculation in a lower motor neuron palsy. And then you will have to look for the area of involvement. Half of the body hemiplegia, bilateral symmetrical, rapidly progressive, will be very commonly seen in Guillain-Barré and also in case of poliomyelitis. We already mentioned generalized wasting in tuberculosis, HIV, thyrotoxicosis, diabetes, malnutrition, those groups. Close to the joint and around the joint, secondary because of severe arthritis. You can have increased muscle mass in case of dystrophy, like limb girdle dystrophy. Single muscle involvement very frequently in a peripheral neuropathy or peripheral nerve palsy. Single group of muscles, and that will be low motor neuron variety. You can also have painful wasting of the muscle in multiple muscles in case of polymyositis, and particularly in a lower motor neuron palsy along with wasting you will see fasciculations. Also fasciculation can be seen in a fatigue muscle. So muscle wasting, fasciculation we have discussed enough, and you have to look at whether it is a generalized, whether it is proximal, whether it is distal, whether it is unilateral, whether it is bilateral, and then depending upon those you will be putting them into upper motor neuron, lower motor neuron, whether it is myopathy, whether it is disuse atrophy, all those words you can utilize. You can see here this as hypertrophic muscle. This is muscle hypertrophy. All muscles are undergone hypertrophy. So this will be in an athlete. While here, if you compare right with left, this side there is a little amount of atrophy. So this is unilateral. And when it is unilateral, it has to be either, if it is extensive, it will be more common with upper motor neuron because of disuse atrophy. Here you can see there is a wasting of the muscle with fasciculation. So this is lower motor neuron, seen very frequently in a motor neuron disease. Again you can see here the wasting of this particular portion. Again this will be more common with lower motor neuron. This will be seen very frequently in a dystrophies. This is also seen in a dystrophy. Pseudohypertrophy. So those are called dystrophies. You can see here there is a winging of scapula, and this will be very frequently in a atrophy of the muscle, and that will be in a fascioscapular dystrophy groups of disorders. Here you can see in upper motor neuron you have got one side drooping. You can see the drooping here. Nasolabial fold is clear, angle is lifted up. Here no nasolabial fold, nasal part is drooping down. There is a poor contraction of the eyelid, but there is a slight furrowing. So orbicularis oculi and frontalis belli are working. So this is an upper motor neuron because of damage to the opposite side. So this is an involvement of the right side. So person has got damage to the left side pyramidal tract. While here you can see drooping, nasal part is drooping, no nasolabial fold. Furrowing is, you can compare with opposite side. Furrowing is nearly absent. There is no lifting up of the eyebrow. Eye cannot close. So orbicularis oculi and frontalis belli action is also absent. So complete half side palsy. It is locomotor neuron palsy. And then later on person can develop atrophy. Sometimes you can see an involuntary movements like spasms. So that is a repetitive twitching of the muscle. We call that as a tics. In seizure, it will depend upon the type of seizures like partial or generalized. In chorea, you will have a movement along the axis, involuntary, abnormal, pseudo-purposive movement seen in a chorea. There are two types of chorea, one in rheumatic, one in what we call as a Huntington chorea. And in rheumatic chorea, we call as a rheumatic chorea or Saint Vitus dance. So that is typical in rheumatic chorea. If you get an axial movement, rotational movement along the long axis of the arm with little abnormal movement of the distal part of the limb, that is called athetosis. Myoclonus is sudden spasm of the group of muscles. Sudden spasms, that is called myoclonus. When there is a decreased movement, it is very frequently because of the increased tone in the muscle, and that we call as a bradykinesia. Along with that, there will be rigidity, postural instability, and resting tremors. That will be very classically seen in case of a Parkinsonism. We usually use the word trap, that is tremor, akinesia, rigidity, and postural instability. And in dystonia, there is one group of muscle which undergoes spasm. So that is dystonic disorders. So chorea is sudden, irregular, purposeless or pseudo-purposive movements affecting the big proximal joints, while athetosis is slow twisting movement affecting the distal joints. Dystonia is a slow twisting movement of the trunk part of the joint, trunk part. While tremors are rapid alternative movement around the small joints, which can be static tremors or which can be intentional tremors. Intentional tremors are common in cerebellar disorders, while static tremors are more common with Parkinsonism. This is typical athetosis. This is tonia, dystonia. This is chorea, very commonly seen in a rheumatic chorea or we call as Huntington chorea. And these are tremors, alternative rapid movements. In a limb girdle myopathy, you will have a girdle muscle being involved. And in case of a Duchenne myopathy, you will have a typical Govers sign. We'll be discussing when we discuss in a chapter of myopathy. And we'll be showing you those photographs also. Some of the signs which can be demonstrable, that is meningeal irritation signs and typical posture, we call as knee chest posture. Very commonly seen, or the sometimes you describe that as chin chest test, chin knee kissing test, and tripod signs. These are commonly seen in a case of a meningeal irritation. And you can demonstrate neck stiffness, back stiffness, Kernig sign, Brudzinski sign, and even Brudzinski neck sign and Brudzinski leg sign. This will be more demonstrable. Kernig and Brudzinski sign will be more classically seen in children. It is difficult to elicit in adult. So this is a Kernig sign where you flex at hip, flex at knee, and then extend at knee. Person will be complaining of sharp pain, and this is typical Kernig sign. And when you flex at neck, and during that flexion you get a flexion at hip and flexion at knee, that is Brudzinski sign. Typical posture, if there is a complete flexion of upper limb and flexion at wrist, this is decorticate posture, and inward rotation of the lower limb, that is decorticate posture, or we call flexure posture, while extensor posture, that is extension at elbow and external rotation, that is decerebrate posture, and limbs will be externally rotated. And if there is a complete flaccid part of upper limb and lower limb, that will be typical in a terminal stage. Muscle tone is the amount of resistance felt during palpation of the muscle in a resting condition, or we call relaxed condition, not during active contraction. So you look at that particular thing, that we call as a muscle tone. Muscle tone will be reduced. So if you keep in this position and if it falls, that is hypotonia, or we call flaccid muscles. So whichever muscle you are examining, muscle tone can be examined only by palpation. The tone will be increased. In upper motor neuron, the word utilized is spasticity, and when it is in extrapyramidal, the word utilized is rigidity. In upper motor neuron, it is increased in one group of muscle. So in that particular direction, you will get resistance, and that's why it is called spasticity. While in case of extrapyramidal, all muscles are involved. So you will have in all direction, flexion, extension, etc. And that is called rigidity. And in rigidity, we have got two types of rigidity. One we call cogwheel rigidity, and one we call as lead pipe type of rigidity. I will be uploading one video lecture, small video clips showing you all those different types of rigidity, spasticity, etc. And if there is a complete loss of tone, we call flaccidity. So these are the three common words which will be utilized in tone. Hypotonia, hypertonia, and in hypertonia 2, spasticity, rigidity, and in rigidity 2, cogwheel and lead pipe. And in spasticity, we usually use the word clasp knife type of rigidity. So that will be very typical. So flaccid can be central or can be peripheral. And in spasticity, it is mainly because of corticospinal tract damage, and rigidity is because of Parkinsonism or basal ganglia, and dystonia will be very frequently seen in a basal ganglia damage. So testing for the spasticity, you hold the patient hand and then do flexion and extension. Rapid supination and pronation at elbow, and you will be able to find out whether there is any spasticity or not. If it is found in only one group of muscle and opposite of group of muscle there is no resistance, then it is more in favor of upper motor neuron. And you will get classical, what we call as, while flexion and extension you will be able to demonstrate much better, and that will be very frequently you will be able to demonstrate clasp knife type of rigidity. So similar thing you can do in a lower limb, that is you rotate the limb, external internal rotation, and try to find out whether there is any effect on the tone. And you can look for clonus, we call it the ankle clonus, when you do a dorsiflexion and sustain that dorsiflexion, and if you get a jerky contraction, sustained contraction, repeated contraction, we call that as an ankle clonus. It will be a very good sign in a case of increased tone in the muscle. We call upper motor neuron damage because of increased tone, hypertonia. So you get a plantar flexion extension, flexion, extension at ankle. So it is called ankylosing, and it is a sign of upper motor neuron palsy on that side. So these are the different things. So class type rigidity, you will be able to demonstrate. You will be able to demonstrate ankle clonus or patellar clonus. So this will be very typical in case of a upper motor neuron damage. Initial resistance followed by give way. So when you are doing flexion, initially you will have a resistance and suddenly there will be give way. That will be very typical. You can demonstrate in upper limb, and in lower limb you can demonstrate at knee. And as far as the clonus is concerned, you can do clonus in patella, that is at knee and at ankle. Another way of doing a test is you ask the person to outstretch the arm and tap over them. We call sacking test or drop arm test. So you can put the two legs together like this and just leave it. If it falls like this is not maintained. This posture is not maintained. It will be because of hypotonia. So look for those findings. So we already told you hypotonia will be one of the signs classical in case of lower motor neuron palsy. But in cerebellar disorders also you can get hypotonia, and in a chorea also you can have little amount of hypotonia. Also you can see hypotonia in myopathy, particularly limb girdle myopathy. Also during post-ictal coma you can have hypotonia, and in acute neurogenic shock also you can have hypotonia. In an old person also you will have a bilateral symmetrical hypotonia. In hypertonia in upper motor neuron, we have already mentioned, you will have hypertonia on the side where there is a damage, and that particular will be producing a hypertonia in one group of muscle. While in Parkinsonism, or we call extrapyramidal damage or basal ganglia damage, you will have bilateral increased tone, and that will be involving all group of muscle, flexor, extensor, etc. So that will be in a case of Parkinsonism. So spasticity will be more in upper motor neuron, while rigidity will be in Parkinsonism. Spasticity, usually you will demonstrate increased tone in one group of muscle, and there will be stretch reflex followed by reverse stretch reflex. While here both group of muscles are involved, flexor and extensor, or we call antagonist and agonist group of muscle. You will be able to demonstrate spasticity, very classical in case of upper motor neuron lesions in upper limb as well as lower limb. In upper limb, flexor muscles are more involved and pronator muscles are involved, while in lower limb, extensor and adductors are more involved. While in Parkinsonism, all muscles are involved. And gait, typical in spasticity, will be hemiplegic gait, while in case of Parkinsonism, it will be a short shuffling gait. Usually tremors are not seen in a spasticity, or we call upper motor neuron, while you will have a static tremors very typically seen in case of Parkinsonism. You will have a classical demonstration of a class type rigidity on initial movement followed by give way, while lead pipe type of cogwheel rigidity will be demonstrable in case of a Parkinsonism. This is a very important slide. It will help you a lot in your clinical practice, and can be asked in your oral, can be asked in your theory also. So when you compare with a lead pipe, very difficult to bend. So that type of rigidity if you get, it is called lead pipe type of rigidity. And if you get alternate rigidity, little contraction, relaxation, that is typically described as cogwheel. While initial resistance followed by sudden give way because of typical phenomena we described, stretch reflex followed by reverse stretch reflex. That is class type of rigidity. Class type of rigidity, which you will see in a pyramidal damage, while extrapyramidal damage will produce what we call as rigidity, which can be cogwheel or lead pipe. And here we use the word spasticity. And these are the signs of increased tone, we call hypertonia. So if one group of muscle is involved, you will get class knife type of rigidity, and it is a sign of pyramidal tract damage. Typical initial resistance followed by suddenly give way. So you will have a loss of inhibitory command from upper motor neuron. Typical class knife. While constant resistance in both group of muscle, agonist and antagonist muscle, throughout the movement, that will be typical in an extrapyramidal, we call lead pipe type, or in case of cogwheel rigidity. So that will be the typical description. We already described spasticity, rigidity, flaccid in case of lower motor neuron. Then factors which can affect the muscle tone without any neurological damage, like anxiety, temperature, tension, certain drugs, fear. Fear and anxiety will increase the tone in the muscle, while certain drugs can reduce the tone in the muscle, it will relax the muscle. Certain drugs, tension, anxiety, fear, full bladder can also increase the tone, position of the head, certain environmental condition, hearing, etc. can affect the tone. Usually tone will be affected by stress, anxiety, certain medication, quite common. So that should be kept in mind. But it will be all muscles, not one muscles. Hypotonia will be very common in case of a low motor neuron palsy. But in an acute neurological shock stage, also tone will be reduced. Some of the chorea condition, cerebellar damage, Down syndrome, and atonic cerebral palsy, also you can have hypotonia. When you look for the muscle power you look in a single muscle, group of muscles, and you always compare with right and left, and you can compare with your own when there is a bilateral involvement. So you can compare with your own. So you are comparing with your own, and you can compare with right and left, and you can compare in single muscle and group of muscles. When you are examining a group, say it is like flexor, extensors, adductors, abductors, etc. And try to identify the power. And power we divide into 5 stages. So while examining the power, you have to look at the proximal muscle, distal muscles, and then put them into a group: monoparesis, hemiparesis, paraparesis, quadruparesis, whether it is paresis or plegia, depending upon the power. If it is 0 power, it is plegia. If it is reduced power, paresis. And then you can mention proximal muscle weakness, distal muscle weakness, complete limb gone, lower limb, upper limb, both lower limb, para, one upper limb and one lower limb on the same side, hemiplegia, one single limb, mono. So depending upon that we use. So if there is no muscle movement, power 0. And we compare with our, we call 5. If there is just flickering movement, we call 1. If there is a movement at joints, but not against gravity, power 2. Against gravity, but not against the resistance, power 3. Against resistance, power 4. And full strength, power 5. And in an athlete, you can have more than your power. It will be more than 5. We call 6 by 5. Yes, some person who has got a good muscle, they can have power 6 by 5. So this will be the grading. So against resistance 4, full power 5, 3 not against the resistance but against the gravity, movement possible but not against the gravity 2, 6, sorry this should be 1, it is mentioned 6, wrong, this should not be 6, almost flickering movement only, power 1, no movement, power 0. So you can examine in individual muscles, you can examine in group of muscles, and you should know the root value of those. So depending upon that, adduction, abduction, flexion, extension, adduction, abduction, all those rotations in upper limb, lower limb, fingers, toes, etc. You examine at different level and you should know the root value. And then you can say that this group of muscles are involved, so probably this root must be involved. So you look at the different joints. I'm skipping over all this. So power 0 very frequently in a classical lower motor neuron, and reduced power less than 5 but more than 1 very frequently seen in a upper motor neuron. Also power will be reduced in myopathy, in cerebellar disorders. Also there will be effect on the power because of increased tone in the muscle due to extrapyramidal disorders. So power markedly reduced in a small group of muscles, very frequently seen in a lower motor neuron. But some condition can be extensive lower motor neuron. Classical example, Guillain-Barré, poliomyelitis, motor neuron disease. These are lower motor neuron and you can have an extensive involvement. But in a peripheral nerve involvement, you can have only few muscles or few groups of muscles only. Then you can go for posture and gait equilibrium examination. We'll be dealing separately. Gait will be dealing separately. Posture also will be dealing, and equilibrium. While testing for equilibrium, the commonest test which is very frequently being done is Rhombug test. Here just this is a posture, typical posture, very frequently seen in a what we call as meningitis, also in case of tetanus. This is typical dystonia. This is decorticate posture. This is complete flaccid. This is decerebrate posture, or we call extensor posture. This is because of extensive damage to the cortex as well as the brain. While here damage to the cortex part. And this is extensive damage extending up to brainstem, where you will have a flaccid palsy. Gait can be affected because of tone, because of strength, because of balance, because of sensory system input, and because of coordination. Coordination will be affected very frequently because of cerebellar disorders. This will be because of severe peripheral neuropathy. This will be because of lower motor neuron or upper motor neuron palsy. And tone will be affected because of lower motor neuron, upper motor neuron, or because of extrapyramidal disorders, or even because of cerebellar disorders. And also balance can be affected because of visual input, vestibular input, proprioceptive input, and cerebellum. So all this can affect the gait. We are not discussing, we'll be having a separate lecture on gait. So gait is how the person is walking in a straight line on a bare foot. And then there are different types of walking. You will have a spastic gait, scissors gait, propulsive gait, high steppage gait, waddling gait, etc. Different types of gaits. We'll be discussing, and probably I'll try to get the clips on these different gaits and we'll demonstrate those on video lectures. You can have in coordination in case of cerebellar disorders, in upper limb finger nose test, finger test, then didacokinesia in lower limb knee heel test, and making a circle in the air with the toe, etc. And whole body coordination you can test by Rhombug test, by tandem walking and walking on a straight line. We'll be doing separately in a cerebellar disorders. So this is a tandem walking, this is walking on the toe, this is again tandem walking, this is walking on a straight line, this is Rhombug test, this is standing on one foot, etc. So this is tandem walking, this is on the toe, this is on the heel, this is Rhombug test, this is hopping, and this is walking with a broad base. This is tandem walking, this is hopping, etc. These are all done to differentiate cerebellar from sensory ataxia. If person is can maintain balance with open eye but starts getting ataxia, with closed eye more in favor of sensory, while in cerebellar with open or with closed eye remains same. One simple way to differentiate sensory from cerebellar. While doing a Rhombug test, always stand on the back, see that the person doesn't get a fall. And if Rhombug test is positive, either it is sensory or because of cerebellum or because of vestibular apparatus. Three disorders will produce Rhombug test positive. So we'll be discussing in detail. The person has to stand with two legs together, arms by the side, eye closed. First initially eye open followed by eye closed. And if a person can maintain the balance, Rhombug test negative. If person sways, Rhombug test is positive. It will be common in case of sensory ataxia, cerebellar ataxia, and vestibular disorders. So sensory and cerebellar ataxia you can differentiate, and also you can make little more sensitive by just tapping the person, and that is called modified Rhombug test. You will be able to differentiate between sensory and vestibular ataxia. Then there is one sign called as a Bariness sign, that is Pronator Drift. You ask the person to keep the both arm outstretched. So slowly one arm will undergo pronation, and that will be very frequently seen in a person with cerebellar signs, cerebellar disorders. It is called Barry's sign or Bariness pass pointing, Bariness pass pointing test, or it is also called as drift, pronator drift. So pronator drift will be very clearly demonstrable. If you ask the person to keep the arm straight like this, there will be drifting of one arm, affected arm, that side cerebellar disorders. So it is very commonly seen in cerebellar disorders. So that will be one test will be helpful. Bariness pass pointing. Again you can see this is drifting. That will be seen in cerebellar disorders. You can see the two outstretched arm and slowly the one arm undergoes drift. There is one test called as a Hoover's sign, and this will be to differentiate between the organic and inorganic or functional and organic. So if there is a true paralysis, you will be able to demonstrate Hoover's sign, while in case of a functional or we call malingering or hysterical, Hoover's sign will be negative. I've uploaded one video on this particular signs. You can go through at leisure time. Then these are all the different types of involuntary movement you can demonstrate. There are hypokinetic disorders like akinesia or because of rigidity. And there are some hyperkinetic disorders like tremor, dystonia, myoclonus, chorea, athetosis, tics, etc. And mixture you can get in case of a cerebellar disorder in miscellaneous disorders, that is resting leg syndrome, etc. Those group of disorders. Just out of way. If possible, I'll try to upload this video. So these are all different types of involuntary movement. Hyperkinetic movements like tremors, etc. And hypokinetic movements. These are hyperkinetic movements. And these are abnormal movement like spasm, fasciculation, chorea, athetosis, hemibellismus, tremors, etc. So I end my lecture here. Thank you all for taking out time. I know that your time is valuable, and I appreciate that you have spent some of the time with me. Motor system examination will be very, very helpful in a neurological examination to differentiate between upper motor neuron, lower motor neuron, and by examining the tone, etc., you will be also able to identify whether it is an extrapyramidal or not. So this will be very, very helpful. So do a proper motor system examination like inspection, palpation, percussion, and then you look for the tone, you look for the power, you look for involuntary movements, etc. You will be able to pick up good number of conditions. You will be able to identify. At least you should be able to differentiate between upper motor neuron and lower motor neuron. And also, you should be able to pick up hypertonic conditions like Parkinsonism. So I end my lecture here. If you like this particular lecture, please don't forget to press button like, subscribe and share with your friends. See you in next lecture.